The Kanski lecture series, and in this lecture, we are going to discuss about the vascular tumors. So, in this part, we are going to discuss about the varices, lymphangioma, capillary hemangioma, cavernous hemangioma, and that's it. So, let's get started with the varices. Introduction. Primary orbital varices combine villous lymphatic malformation of the orbit. See also next topic. Consist of a plexus of a thin walled distensible low flow vein like vessels that are commonly, though not always, intrinsic to the normal circulation. So basically, these are usually, but not always, the part of a normal circulation, and there is a plexus of veins like vessels, and they are distensible. So it will increase on the all of this vascular tumor, they increases on the valsalva maneuver. They are probably hematomatous. Hematoma, a disorganized overgrowth of a mature tissue normally present in an involved area. Association include the varices of the eyelid and C and the conjunctiva. They are commonly present at any time from early adulthood, childhood to the late middle age, but occasionally can be acquired later secondary to the high flow vascular lesion or trauma. So basically, there is a term known as hematoma and a term known as choristoma. So hematoma is a abnormal growth of a normal tissue in a normal location, whereas choristoma is a abnormal growth of a normal tissue in an abnormal location. So diagnosis, most cases are unilateral and most frequently site is upper nasal. So its site is upper nasal. Intermittent non-pulsatile proptosis, so there will be can be the pulsatile proptosis which will be the intermittent, but it will be without a bruit is reported if there is a free communication with the normal circulation. A reversible proptosis may be precipitated or accentuated by increasing venous pressure through cuffing, straining the valsalva maneuver, assuming a head down position, or a external pressure or a compression of the jugular vein. So sometimes it may increase on the valsalva maneuver. So we can see the figure 4.31. A is showing us the eyelid varices, B is showing conjunctival varices, C is showing orbital varices with before valsalva, and D is showing with valsalva, showing forward movement of the eye and the fullness of the upper lid. E is showing axial CT, showing medial opacification and phlebolytics. Very important. We will discuss what is phlebolytics. It is basically a diagnostic sign of a varices. And EF is showing the left fat atrophy resulting in anophthalmos and deep superior sulcus. So, what are investigation will you perform in a case of varices? Imaging, for example, MRI and MRV, CT scan, ultrasound, and venography shows a lobulated mass with a variable contrast enhancement and may demonstrate phlebolytics. And sometimes orbital expansion, particularly in childhood or an associated orbital wall defect. Complications include acute orbital hemorrhage, thrombosis, pain, proptosis, and decreased vision, optic nerve compression. Patient with long-standing lesion may develop atrophy of a surrounding fat, giving anophthalmos with a deepened superior circle. So there are certain complications that can be associated with the varices. It can bleed and can cause the orbital hemorrhage. It can cause optic nerve compression or can cause thrombosis. And if there is a long standing case, and there is can be the atrophy of fat, and after that which is under anophthalmos and deepened superior sulcus. So another term is phlebolytics. So basically the phlebolytics are the clotting or calcification that happened in a vein. So these are characteristic of a varices. Treatment. Small lesions generally do not require treatment. Surgical excision is technically difficult and often incomplete because the lesion is febrile and friable and bleed easily. So remember that these lesions of varices, we are talking about the orbit. So it is not that superficial that you can excise at any time. It is present deep, first of all, and secondly it has a vascular channel. So what if you remove it, will can cause a bleeding, and it is very difficult to remove. And it may be complicated by the severe orbital hemorrhage, and it can cause optic nerve compression. So it can be complicated by the severe orbital hemorrhage and vascular or optic nerve compromise. Specialized techniques such as embolization and carbon dioxide laser surgery may be helpful adjunct. Indication include recurrent thrombosis, pain, severe proptosis, and optic nerve compression. So there are certain indication for removal of the lesion. If there is a recurrent thrombosis in case, if there is a severe pain, there is a severe proptosis, and there can be optic nerve compression, then you can do the surgical excision of that. So another thing is lymphangioma. So lymphangioma is a rare hematomatous vascular tumor that tend to enlarge and infiltrate diffusely with time. Some authorities believe lymphangioma to be the variant of the venous orbital anomaly, varices across a single spectrum, and a term combined venous lymphatic malformation of the orbit has been suggested. Although usually isolated from the main circulation, bleeding into the lumen may occur with subsequent formation of the blood-filled chocolate cyst that regress spontaneously with time. Presentation is usually in early childhood. Differential diagnosis is principally from the orbital venous anomalies and hemangiomas. Intracranial vascular malformation can be present in association. So basically, it is also a lymphangioma means that there is a lymphatic there is a lymphatic system and there is a vascular system. So whenever the lymphatic vessels are enlarged, these are called known as lymphangioma, and the bleeding in these channel can causes the formation of a chocolate cyst which can regress spontaneously, and presentation is in early childhood. Diagnosis: anterior lesion typically manifests as a severe soft bluish masses in the upper nasal quadrant. So it is also common in a supranasal quadrant. Posterior lesion may cause progressive proptosis or initially may lie dormant and later present with the sudden onset of a painful proptosis. Secondary to the spontaneous hemorrhage, which may be associated with optic nerve compression. Involvement of the lid, conjunctiva, and oropharynx may be seen. Intracranial lesion may also be present. So you can see this figure 4.32, which is showing us the anterior orbital lymphangioma. It has a typical bluish discoloration, whereas the posterior lymphangioma causes the proptosis. And if there is a bleeding in the posterior lymphangioma, it can cause the severe proptosis as well. So this is a CT showing us this is an MRI showing us the proptosis and the retrobulbar lymphangioma. Treatment: in many cases, the visual prognosis is good. Without treatment, surgical excision is difficult because lesions are not encapsulated, friable, bleed easily, and commonly infiltrate normal orbital tissue. So, both the varices and lymphangioma, surgical excision is difficult because it bleeds easily. Repeated subtotal excision may be necessary. Persistent site-threatening chocolate cyst can be drained or removed subtotally by controlled vaporization using a carbon dioxide laser. So if there is a recurrent formation of a chocolate cyst, you can use the carbon dioxide laser for the vaporization, and this is how we treat the lymphangioma. Basically, you treat varices and lymphangioma with observation until it is very necessary to remove the lesion through surgery. Next is a capillary hemangioma. So capillary hemangioma is the most common tumor of the orbit and the periorbital area in childhood. Girls are affected more commonly than boys. It may present as a small isolated lesion of a minimal clinical significance or as large disfiguring mass that can cause visual impairment and systemic complication. An established tumor is composed of anastomosing small vascular channel without true encapsulation. So basically, the capillary hemangioma is also the growth of a it is a hematoma, which is basically the growth of a mature tissue in a normal location in an abnormal pattern. So basically, the capillaries which are present are having a overgrowth in a case of a capillary hemangioma. So when it involves the orbit, it is known as orbital capillary hemangioma, and it is more common in female. An established tumor is composed of anastomosing small vascular channel without true encapsulation. So there is no true encapsulation. It is a hematoma, disorganized overgrowth of a mature tissue, normally present in the involved area and believed to be due to surgically, principally due to endothelial cell proliferation. Large or multiple lesions may have associated visceral involvement, which can lead to the serious complications such as thrombocytopenia, Kasabach-Mariette syndrome with up to 50% mortality and high output cardiac failure. And systemic investigation should be considered. The incidence of infantile hemangioma in a general population is around 5%, and proportion of which of these, especially if a large facial hemangioma is present, will have a faces syndrome, which include a range of possible systemic features including eye involvement. So there is certain systemic involvement of the capillary hemangioma. One is a Kasabach-Mariette syndrome. Basically, in this there is a thrombocytopenia and there is a high output cardiac failure with it. Next is a faces syndrome. The faces syndrome have a different types of organs that also have a capillary hemangioma, especially if the large area of face is involved. You can say that it can be a faces syndrome, but there are other anomalies as well. Uh, it can be heart, it can be chest, so it can be eyes as well. Next is diagnosis. The lesion is usually noted by the parent, usually in the first few months of life. Approximately 30% are present at birth. Signs are extensive. Underlying orbital involvement should always be ruled out in a seemingly purely superficial lesion. A superficial cutaneous lesion, strawberry nevus, is bright red. Perceptible deeper tumor appear dark blue or purple through the overlying skin and are most frequently located superiorly. So you know that there can be the superficial capillary hemangioma, which is present superficially in the skin, which is about red in color, whereas the dark lesion is basically purple or blue in color. And the superficial capillary hemangioma blanch on pressure, and it also increases in the Valsalva maneuver. A large tumor may enlarge and change in color due to deep blue during crying or straining, but both pulsation and blue are absent. Deep orbital tumors give rise to a unilateral proptosis without skin discoloration. Hemangiomatous involvement of the palpebral or fornical conjunctiva is common. Additional hemangiomas on the eyelid or elsewhere is common. Investigation imaging is generally performed for other than very small lesion, mainly to rule out extensive orbital disease. Ultrasound show the medium internal reflectivity. On a MRI or CT, the lesion appears as a soft tissue mass in an anterior orbit or an extraconal mass with a finger-like posterior expansion. Very important that it is an extraconal mass and it will have a finger-like projection like a dural, and it shows the posterior expansion, and it has a medium internal reflectivity. The orbital cavity may show enlargement, but there is no bony erosion, and there is no bony erosion in this. So you can see imaging of a capillary hemangioma and axial enhanced CT showing a homogeneous intraconal orbital soft tissue mass. So there is a homogeneous intraconal soft tissue mass. So it can be extraconal and intraconal as well. So if it is an extraconal, it will have a finger-like expansions. So a figure 4.34 also showing the capillary hemangioma. A is showing the large preseptal tumor causing ptosis and purple cutaneous discoloration. There is a superficial component, a strawberry nevus involvement of a fornical conjunctiva as well. So how will you treat the case of a capillary hemangioma? The natural course is characterized by rapid growth 3 to 6 months after diagnosis, followed by slower phase of natural resolution, in 30% of which lesion resolved by the age of 3 years and 75% by the age of 7 years. So basically, the capillary hemangioma can resolve on its own by growing. It usually have show a first a rapid growth pattern, and then there is a regression. So 30% of the cases are treated spontaneously by 3 years and 75% by case of 7 years. Treatment is indicated principally for amblyopia secondary to induced astigmatism, anisometropia, occlusion, or strabismus, less commonly for cosmesis, optic nerve compression, or exposure keratopathy. So there are certain indication why you treat the patient with a capillary hemangioma. So one of the thing is to prevent amblyopia, anisometropia, astigmatism, any strabismus, and for optic nerve compression or exposure keratopathy. So mainstay of treatment is beta blocker. Oral propranolol is now widely used. The prescription and monitoring should generally be carried out by a pediatrician. Topical preparation include timolol are equally effective with excellent long-term result and no systemic side effect. So you can give the pediatric patient a oral beta blocker, as well as you can put the ointment on the lesion, which is a timolol as well, and it is showing the promising result as well. Another thing is you can also give the steroid injection of the triamcinolone acetonoid 1 to 2 ml, total of 40 milligram per ml over several injection sites, or betamethasone 4 milligram per ml into a cutaneous or preseptal tumor is usually effective in early lesion. Regression usually begin within 2 weeks, but if necessary second or regression usually begins within a 2 weeks, but if necessary, second, third injection can be given after about 2 months. It is advisable not to inject deeply into the orbit for the fear of causing occlusion of a central retinal artery due to retrograde introduction of a suspension. Other complications include skin depigmentation and necrosis, fat atrophy, and systemic effects such as adrenal suppression. Topical high potency steroids such as, for example, clobetasol propionate cream are sometimes appropriate but are slow to exert their effect. Systemic steroids administered daily over several weeks may be used, particularly if there is a large orbital component or a rapid onset of action is required. So you can give the steroid injection as well. Most common is an intralesional triamcinolone acetonoid, and you give the 1 ml of injection on to the lesion, and you can also give the betamethasone, but there are certain side effects. If you inject very deeper into the orbit, it can cause central retinal artery occlusion, as well as it can also cause the fat atrophy, it can cause necrosis and skin depigmentation as well. Laser may be used to close the blood vessels in a superficial skin lesion less than 2 mm in thickness. So if the capillary hemangioma is less than 2 millimeter in thickness, it can cause. So next is like there is a if there is a 2 millimeter thickness and you put on the laser, it can close the blood vessels in the superficial skin. Next is alpha interferon alpha 2a and vincristine may be used for some steroid resistant site threatening lesion. Local resection with a cutting cautery or carbon dioxide laser may reduce the bulk of an interior circumscribed tissue, but is usually reserved for the late inactive stage unless a resistant tumor is site or life threatening. So local resection can also be used, but it is done when all the other measures have been failed and the tumor is site or a life threatening. So next is the cavernous hemangioma. Introduction: cavernous hemangioma occur in middle-aged adults with a female preponderance of 70%. The growth may be accelerated by pregnancy. It is most common orbital tumor in adults and is probably a vascular malformation rather than a neoplastic lesion. So remember, the difference between the capillary hemangioma and cavernous hemangioma is that a capillary hemangioma is present in case of infants, But the cavernous hemangioma occur in a middle-aged adult, and there are certain vascular malformation that occur in a case of adult, and it is most commonly in a female and especially in a pregnant woman. It is the most common orbital tumor in adults and is probably a vascular malformation rather than neoplastic lesion. Although it may develop anywhere in the orbit, it most frequently occur within a lateral part of the muscle cone just behind the globe and behaves like a low flow arteriovenous malformation. So, very important, usually it is an intraconal mass. Cavernous hemangioma, and it occur in the lateral part of the muscle cone and it behaves like a low flow arteriovenous malformation. So, histology show a endothelial lined vascular channel that is separated by a fibrous septa, very typical histopathological picture of cavernous hemangioma. Diagnosis, slowly progressive unilateral proptosis. So, there will be the proptosis, bilateral cases are very rare. Signs are the axial proptosis, which may be associated with optic disc edema and choroidal folds. A lesion at the orbital apex may compress the optic nerve without causing the significant proptosis. Case evoke transient blurring of the vision may occur. Very important is that the patient may present with the axial proptosis, and there can be a optic nerve compression if the lesion is as the orbital apex, and there can be, if the patient is looking at the certain gazes, it can cause the transient blurring of vision, very characteristic of a cavernous hemangioma. There may be impairment of the ocular muscle excursion. Investigation: CT and MRI show a well circumscribed oval lesion, usually within a muscle cone. So there will be the circumscribed oval lesion within a muscle cone. There is only slow contrast enhancement. Ultrasound is also useful. Treatment: many cavernous hemangiomas are detected by chance or the scan performed for unrelated reason, and observation alone is often appropriate. Symptomatic lesion requires surgical excision in most cases because they gradually enlarge. The cavernous hemangioma and its capillary counterpart is usually well encapsulated and usually easy to remove. So, very important about the cavernous hemangioma is that it is a well encapsulated lesion and it is quite easy to remove. So if the lesion is symptomatic, then you can remove the cavernous hemangioma. So you can see the figures. These are the growth of a capillary hemangioma. A is showing a presentation, B is showing several months later, C is showing at presentation, and D is showing the 6th month later after with the topical beta blocker. And cavernous hemangioma histopathology show congested, variable sized endothelial line vascular channel separated by fibrous septa. B is showing the right axial proptosis. C is showing the axial CT scan showing a well circumscribed retropulbal oval lesion and proptosis, and D is showing the tumor is encapsulated and relatively easy to remove. So that's it for the orbit part 6. See you in the next lecture.